Hello, good afternoon to everyone. It is my pleasure to chair this session today of deep brain stimulation in Parkinson's, patient selection, pathways and pitfall, sponsored by Zampon UK. The first session is organized by Parkinson Academy, sponsored by Zampon UK. And this is our speakers. We will discuss about DBS. The first talk will be myself on selection of patients, and then we will have Joseph Candelario McCown that will talk about the specific pathway that we use in DBS from clinic to surgery. And finally, Dr. Antonella Mascherollo, that is a consultant neurologist, who will talk about pitfall, expectation. Very nice program, well structured, and we hope to cover all the aspects of DBS in this very short time. So let's start. So we have more time for discussion. So the first talk will be about identification of the ideal DBS candidate. So who, when, and why. And these are my disclosures. And let's start with what are the nice guidelines. They were reviewed in 2017, and the main consideration about deep brain stimulation is that deep brain stimulation should be offered to people with advanced Parkinson's disease, particularly when their symptoms are not adequately controlled by the best medical therapy. They also say that DBS should not be offered to people with Parkinson's disease where the symptoms can still be controlled by medical therapy. This is arguable, and then I will show you a study that demonstrates actually the opposite. So first of all, what is Parkinson? What is advanced Parkinson disease? How do we recognize when a patient has advanced Parkinson disease? Of course, it's different. It's different from patient to patient. It's different from the phenotype of Parkinson's. But there are some criteria that have been suggested not long ago that should help us to recognize patients who have a more complex disease. And these are the 5-2-1 criteria that were established by Delphi Consensus. So they have been proposed to help to understand when Parkinson's have become more advanced. So when patients are in a more advanced study that need some more complex therapy. And it's not only useful for DBS, but it's also useful for other complex device-assisted therapy like infusions, apomorphine infusion and levodopa infusion. What are these 5-2-1 criteria? I'm sure many of them are familiar with this. Is 5 times of levodopa, 5 administration of levodopa a day, at least 2 hours of off periods during the day. So when patients are struggling with their symptoms despite the treatment, and this can be wearing off or can be sudden on off medication, but also can be delay of effect of the medication. And finally, 1 hour of troublesome uncontrolled dyskinesias. Now, if a patient has any one of this, or at least one of this, Parkinson can be considered advanced. And so patients could be considered for more complex therapies, including DBS. But who should we refer for DBS? First of all, we want patients that have at least 4 or 5 years of disease. This because sometimes in these early years, there are an overlap with other typical Parkinsonism like MSA, PSP. So sometimes it's difficult to recognize people with isolated with idiopathic Parkinson's disease. And therefore, we might perform surgeries in patients with atypical Parkinsonism that usually do not respond with DBS. The only exception to this is if people have very troublesome dominant, tremor-dominant Parkinson's with clear indication that is idiopathic Parkinson, because in that case, we can also do that slightly earlier. The symptoms need to be bothersome, and despite the medications, or can also be that patients are on a low amount of medications but have significant side effects, and that can be related to headache or dystonia or dyskinesias and so on. One important thing is that patients still need to respond to dopaminergic medications, because DBS does what a large dose of dopaminergic medication do. So unless there is a good response to medications, DBS is not going to help. And then, of course, is a surgery, so there should not be any contraindication to surgery. So we expect people to have a good health, have not major significant problems. Usually, we need people who are not on anticoagulant, or they can stop anticoagulant for a while because there is a risk of bleeding, as we will see. And of course, if there are several mental issues like dementia or psychosis, we don't tend to suggest DBS. There are other factors that we need to consider, and these are contraindication for DBS is age. So people over 75 usually are not a good candidate. There are other comorbidities, but if someone is very fit, we can still consider. So it has to be done case by case. If it's a moderate cognitive impairment, or for example, more severe, we think that the person is on the way to develop a dementia, we tend not to have DBS because these symptoms can be accelerated or can go worse. While if it's very mild, or as we expected in Parkinson with problem with executive functions, we still go ahead with it. If there are a gait and balance problem in the on state, that would suggest that there is a non-dopaminergic mechanism underlying the symptoms, DBS is not a good thing because they don't improve and actually can go worse. So axial symptoms are very important. Another thing that we consider is when people have a poor on states, if they are not happy with their on, the best time of the day, usually they are not improving with DBS because they again suggest that there might be non-dopaminergic mechanisms causing their symptoms. One exception that is important to consider is tremor, because very often tremor is not responsive to dopaminergic medication, but still responds very well to DBS. So you see a patient who has a tremor despite the dose of 300 milligrams of levodopa that was given as a challenge. You can see he has a significant resting tremor, and there is also some re-emerging tremor. If you can see here, there is some postural and is a clear re-emerging tremor. So that is still considering resting tremor, despite 300 milligrams of levodopa. In this patient, DBS worked very well, and you can see that the tremor has completely disappeared. So the tremor is the only symptoms that, even if it's not dopaminergic, not responding to dopaminergic medication, can be used in patients with Parkinson. We have 3 different targets that can be used for tremor, including the thalamic VIM, but the thalamic VIM is only effective on tremor, not on bradykinesia and rigidity, so it's only for patients who have a very tremor dominant only. I mentioned that NICE guidelines do not recommend to offer patients who can be controlled with therapy, but there is this very nice study that is quite old now that has clearly demonstrated that neurostimulation is better than best medical therapy in early patients, and you can see that there is also an improvement of different aspects of quality of life as measured by the PDQ-39 questionnaire. So if the patients have, even early patient can be considered for DBS. And these are my conclusion. The 5-to-1 criteria might be an objective way, very simple to recognize people who might be ready to have a complex therapy, including DBS. DBS is also beneficial to improve quality of life even in early patients, so not necessarily advanced patient. And DBS is effective on all of the dopaminergic responsive, levodopa responsive Parkinsonian symptoms, including the tremor when is not levodopa responsive. Finally, if people have noticeable cognitive impairment, if there are gait and balance problems during the on state, these are contraindications for DBS. They are not going to improve with DBS, and they can actually get worse. Thank you. And this was the first talk, and we can now move to Joseph, who will talk about the pathway from clinic to surgery. Thank you, Joseph.
So I'll be talking more about the DBS pathway from clinic to surgery. So these are my disclosures. This is the outline of my talk. I'm going to go through them just because of time. Now, overall, the DBS pathway is long. It involves a lifelong care per patient all the way to the palliative end-of-life care per patient. It involves battery replacement, routine follow-ups, reassessment, surgical revisions if needed, and a DBS reprogramming for the patients. For this talk, I'll just be talking about this little section here at the beginning, from the referral to surgery. I'll be talking about the pre-DBS assessment, MDT, the pre-assessment, all the way to surgery and to the first consultation. Now, in the UK, we have 17 centres that actually provide DBS surgery for the patients. And this MDT approach is always going to be the standard, gold standard of care for the patient. You should have the whole team that I presented here. But I think in line or in terms of referrals and managing patients in the actual pathway, apart from the nurse specialist, the team coordinator plays a big role in this, because the team coordinator plays a part in terms of keeping an eye on who are the patients that have been referred, who are the patients that seen the consultant neurologist, all the way to the pathway, building up to the surgery. So I must say that having a team coordinator in the team has been really helpful. We're quite lucky in the UK that nurse specialists play quite a big role in DBS service. Some service is the nurse specialist that plays a bit more role in the programming. Some other services, it's the consultant neurologist or the consultant neurosurgeon. There are some centres who, rather than having a nurse specialist, they have a physiotherapist, particularly in the pediatric sort of services. I know that physiotherapists play a bigger role in this. I'm not going to talk to you anymore about the actual criteria, because that's already covered by Nicola. But the very first appointment, when a referral comes in, they get booked in to see the consultant neurologist. And from there, they would establish the clinical picture of the patient. They would establish the suitability of the patient for DBS. And usually, they would also mention on the letter what could be the sort of potential target for the patient, because that actually guides us, nurse specialists, when we see the patient for the pre-DBS assessment. And they get referred into the sort of pathway to move on to the pre-DBS assessment with the DBS nurses. So once the patient have gone through that sort of process, we book the patient into the for the first pre-DBS assessment, our first consultation with the patient. It's really a great time to get to know the patient. It's also the time to know the patient expectation. And I know that Dr. Antonella is going to be talking to you a bit more about expectations, but it's also a great time for us to document what these expectations are. And we tend to actually document the main symptoms that impacts into their quality of life, and then try to establish how much are they hoping that these symptoms are going to get better. We also establish the psychosocial status. You know, they have a family support. Sometimes you can pick up some history in terms of their cognition, if they're struggling in terms of their day-to-day life. That might be a sign that they have a cognitive issue. Activities of daily living is also established, and we also do a MOCA, just a quick assessment to give us an initial picture if there's anything that we need to highlight with the consultant neurologist. As part of this interaction, we also discuss about the levodopa challenge. We give them the written information, instruction when to stop taking their medication. We normally advise them to be nil by mouth overnight. One thing that we established during this interaction before we do a levodopa challenge is we discuss about the severity of their dyskinesia, and if they have any autonomic symptoms, because that gives us a guidance and a heads up if we need to prepare anything, that we have a bed when we see the patient, particularly if we do the assessment in a daycare or an outpatient setting. We also inform the patient about the risks and the sort of side effects that might happen, because we're going to give them a bit more of a bigger dose of levodopa as part of this test. And also, what's really important is to secure a written consent for the patient, that they're happy to go ahead and they're aware about the risks and the side effects as part of the actual test. In terms of levodopa challenge, we normally do a 12-hour washout, but if the patient cannot tolerate a 12-hour washout, we tend to ask the patient how bad they are first thing in the morning, and we will document whether we need it a little bit shorter. We will always start it at the very start of the morning. We use the MDS-UPDRS scale, and we then define what's the real off when we start the assessment in the off medication, and we also discuss with the patient what's the defined on, and we document if this is representative to their defined off and on at home as well. And we should expect at least about 33% improvement in the score, but on the literature it also says that more than 50% improvement is always associated to a better benefit after surgery. We also document the Hohen-Yahr staging for the patient. If the patient is on a device-assisted medication, we normally stop the pump a few hours before the actual test, because they normally start their pump anyway early in the morning. We ask the patient not to start it, and then we will give them still an oral levodopa. And then we do an assessment after an hour, and then if that is still suboptimal, then we would restart their pump, or in order for us to see what the real on and off symptom. And one thing that we really document here are the response to the axial symptoms. We also make a point whether the patient is struggling to actually cooperate or follow instructions. That might indicate a little bit about executive sort of dysfunction, or whether they have some cognitive issues or mild cognitive issues that are already ongoing. So we also document that. And when we assess the patient in the levodopa challenge, we tend to see them as a whole picture. So if I see them already in the examination room, they don't have a tremor, I still make a point that when I've seen them waiting outside, that they actually had a tremor. Same as freezing of gait. I sometimes don't see that when I do the assessment, but I see them walking, coming into clinic. So I also take that into account as part of my assessment. These are the other scales that we use as part of the assessment. We normally give these questionnaires the day before the levodopa challenge, so they can answer these questions the day before they come into the surgery. Other important investigations is a neuropsychology assessment. We also do an MRI brain scan. Speech therapy assessment is important as part of the levodopa challenge. So the speech therapist sees the patient in the off stage and in the on stage. And if the patient has psychiatric issues, we tend to refer them to psychiatrists before we put them forward to the MDT. The next stage will be an MDT clinic, so we would review all the tests. We also try to make sure that we also discuss with the team about the red flags that we've identified during the assessment. And if the decisions are made, whether we should offer surgery, or we should first optimize medication regime, or we should offer an alternative option, maybe a pump. And if the patient is offered for surgery, then we would then discuss about the appropriate target for the patient. So we normally discuss the pros and cons, side effects, and the surgical complication when we first meet the patient, but this gets reiterated again by the surgeons. And we also discuss what type of battery we should implant to a patient. That's usually documented in the letter. Now, once they are offered with the surgery, and about 2 to 3 weeks before surgery, we do a telephone consultation, a pre-assessment consultation with the patient. We then go through the levodopa challenge test again, make sure that we've got all of that documented in one place. We then look at the bloods. We then document if there's any comorbidities that hasn't been mentioned from the very beginning. We also pre-prescribe medication. One of the worst problems that happens with our Parkinson's patient is when they come to the hospital, SHOs or other medical team re-prescribe their medication in wrong times, in wrong doses. So we make sure that we already pre-prescribe that or have that documented, so they use that as a guide when they prescribe their medication on the admission. We also discuss about reducing some of the medication that needs to be reduced prior to the surgery. We then discuss again with the patient about the complication and the side effect. One thing we establish properly here is the psychosocial and the activities of daily living of the patient, how they are at home. And if we need to refer the patient to OT, we start planning a discharge planning for the patient. And also MRSA suppression therapy is something that we advise. We then do a clinical assessment again when the patient comes into the hospital, just to make sure that it's still updated in terms of their last levodopa challenge. We review the medications that's prescribed properly, whether they've complied with the suppression therapy. We discuss any more concerns or worries from the patient, and then neurosurgical team will then take the consent for the patient. We've done a lot of work in terms of supporting the nursing staff in the ward in terms of managing medication and educating them about what the symptoms are for these patients. And for the surgery, we then withhold dopamine agonists. We then usually put an NG tube in order for us to continue to deliver levodopa even though they are asleep. And in recovery, we also have done a lot of teaching with the recovery staff in terms of identifying the symptoms. Because usually we get phone calls from recovery and they can't even differentiate before what the difference of tremor and dyskinesia, and that's really important so that we know when we should restart the medication once the patient is already awake. Post-op care, we normally advise patients to start mobilizing. They're able to remove all the tubes, keep the TED stockings, we then assess for the patient orientation and behavior, make sure that they're not disorientated or they're not having hallucinations, and we advise them about resuming medication, and we then start planning when we should start the stimulation. Important thing is the surgical care and the discharge planning, again, to discharge the patient. In conclusion, so DBS pathway is a lifelong specialist management care. There are minor variations in different centers, but usually MDT approach still the actual standard of care. Levodopa challenge neuropsychology MRI remains the standard in terms of the pre-DBS assessment, but careful assessment of the mild cognitive deficits, low mood or anxiety must be carefully considered. In the UK, DBS nurses play a bit more role in terms of the patient pathway and in the whole patient pathway from the pre-DBS assessment all the way to the surgery. Thank you. Now I'm going to introduce you to Antonella, who will be doing the next talk.
All right. Good afternoon, everyone. So I'm Antonella Macerollo, and I will speak about pitfall side effects and unrealistic expectation. So the surgical pitfalls, that is very rare, but when this happens, is a significant issue, is device compatibility issues. It can happen that people have a hypersensitivity or allergic reaction on metal component or insulating materials. And these happen in patients that sometimes they don't know that they have an allergies to specific metals, can be completely unpredictable. This is a paper that has been published to try to give some guidelines, but we don't do allergic tests before DBS. And is a very rare. What happened that the healing of the surgical side become very difficult and is very painful. And in this situation, very often the surgeon ends up to remove the DBS completely, the device. Other surgical pitfalls is lead migration. This can happen soon after the surgery for technical error, failure of lead fixation. But also, I have seen few cases where over like 5-6 years or even more, the patient started to respond less to the DBS or with abnormal side effects. And then we checked the position of the lead and there was a migration due to even brain atrophy or other issue that can come. Electrode deformation has been also reported in the literature due to stiffness of the electrode type, brain shift, and surgical accuracy of the implantation. What are the neurological pitfalls? The most important challenges for a neurologist and also for specialist nurse, of course, is after the surgery is to try to work on the process to try to increase the stimulation and reduce the pharmacological therapy. What are the challenges? The time, the necessary time. It is a process and this needs to be communicated to the patients. And we need to be sure that the patient is aware of this. This requires several adjustments, including possible failures, and we need to see the patients again back in clinic and keep changing for a while. In all this process, like when we try to reduce the medication and increase the stimulation, it's also possible that there is a worsening of the non-motor symptoms because we are reducing the amount of dopaminergic treatment. I'm thinking, for example, about depression, apathy, low mood that needs to be managed aside. Side effects. Side effects are surgical related, such as infection. Then when it happened, of course, the neurosurgery team tried to treat, but then it is one of the side effects that required the removal of all the device. Edema and brain hemorrhage are also possible side effects and risk. Misplacement of the electrodes, although it's rare, of course, this can be a human error, although the neurosurgery team now has lots of platform and software for planning, this can happen. Pain and swelling at the surgical site. In my experience, I had a few patients that complain severe pain, even when the swelling around the surgical site has improved. Like a tension on the head, and these are kind of painful symptoms that needs to be managed. Seizures are rare, but it's possible, as in all the surgical procedure. In 15 years working in DBS field, I have seen only one patient had a seizure during the surgery. Of course, anesthesia-related complication in the center where the surgery is done with the patient's sleep. Skin erosion. It's possible to have skin erosion. For example, just this morning, I saw a patient that had a very, very fragile skin, and although is healing around the surgical site, an erosion of the skin came back due to the type of the skin. However, in the clinical environment, what we deal with mostly is with the stimulation-related side effects. For example, muscle spasm or paresthesia that can happen when we do, at least, for example, the first programming session, when we try to understand together with the specialist and nurse what is the best electrodes for the patient. Abnormality of the speech, and balance impairment. So all these side effects related to the stimulation can be improved with changes of the stimulation. It has been reported that the brain stimulation can bring some cognitive changes and mood swings and impulsive control behavior disorder. So these cognitive neuropsychiatric side effects can happen, I would not say frequently, but sometimes. Of course, hardware malfunction, this can happen. The battery, the device is not working well, you do the programming session, and you have lots of technical issues. And the dyskinesia. So the dyskinesia is a side effect related with the stimulation when, for example, the medication are still too high. So these help to understand that we need to work on the medication. Very rarely, it's possible to have a lack of clinical response. Has been very, very rarely reported. It depends on the type of patient's duration of disease and the whole picture. Weight gain is one of the side effects that happen after the surgery, especially if the patient was severely dyskinetic, got the deep brain stimulation, the dyskinesia are getting better, they burn less calories, especially the ones severely dyskinetic, and they can gain weight. I included this slide about the study that we did retrospectively on 137 patients to investigate more the impulse control related disorder, because this is one of the neuropsychiatric symptoms that can be really a challenge in the post-op. So what we found in our cohort is that 37 patients who experienced this condition related to their Parkinson, only 27% patients experienced them after STN-DBS insertion, with 13.5% occurring de novo. So we can have also a new onset of impulsive control behavior disorder in patients that they didn't have this issue before. The de novo group of impulsive control behavior disorder had the Parkinson diagnosis for twice as long as the patients with the pre-operative impulsive control related behavior disorder. And this subgroup of de novo patients demonstrated qualitative clinical improvement with the reduction of the dopaminergic treatment more than the ones that had already a pre-operative issue. So what are the unrealistic expectations? Expecting a cure. So of course, these people are suffering of a chronic condition, and they hope that this can cure the disease is normal. So we need to be very careful to explain that it's not a cure. They can underestimating associated risk and potential side effects. So as Joseph already explained, it's very important to have a complete consent form. And the expectation that it's a quick and effortless improvement. This is not. We need to explain. We require a few months to get the right stimulation and medication after the surgery. Nothing is quick in the deep brain stimulation field. We can have an improvement very quickly of the tremor, but then there are lots of other things to think about. What are the strategies? Education of patients and caregiver, check several times that they are aware and they had the right message. The multidisciplinary approach is fundamental. As Joseph said, the nurses, the physio, the therapist, together with the neurologist, the neurosurgeon needs to be involved. And I think I would speak about my clinical experience. It's important to exploring the patient's priorities. I usually, when I meet a patient, I say, these are the goals of the DBS, for example, motor fluctuation and dyskinesia. What are your priorities? What are you thinking we are helping you for? Because it's important that the goals of the DBS for a clinician and the priority for the patients, they match, or at least this can be clarified before the surgery. And once with, day by day with the clinical practice, you do this, then I understood this is the most important step. But I want to leave you about realistic expectation, because this is very important. This is why we are here today, to listen about DBS. What we are giving with deep brain stimulation is a longer-term improvement of the quality of life. So this complete review done by Professor Limsin and Professor Folteny has highlighted that we can give up to 5-10 years of very good quality of life more to these patients, which is a lot for people that are suffering of a chronic condition. So I always hand my consultation with the patients after discussing all the unrealistic expectations that, of course, people have because they have patients, they are suffering. I always conclude that on the top of the risk and all the time requiring to reach the good balance between stimulation and medication, what we are trying to provide you is a good more 10 years of quality of life. Thank you so much.
Thank you, Antonella and Joseph, for your very clear presentation. I hope we have given a full overview of DBS, very, very short talks, but we are trying to pack everything in there. So I think they have been very, very, very nice overview. There are any questions that we can reply? I noticed that Joseph has already replied to one about the 12 hours. And there are two open one. Both are from Amrit. The first question is about patients on 24 hours for levodopa, carbidopa infusion. So what is the strategy? We don't have a lot of experience in there, at least in Newcastle, because usually the nice guidelines is that the produodopa is given to patients when DBS is not an option. So it should be a second choice compared to DBS. It's not always the case, but that is. Personally, I would say that has to be checked on the days after the surgery, because when people have DBS surgery, usually there is what we call a stunning effect or a macrolesion effect. So the symptoms of Parkinson's tend to improve for up to 4 weeks. So sometimes has to be adjusted according to the need of the patient. Then there is another question about DBS is offered privately. Is there any benefit for DBS in less advanced PD? This early study seems to be quite beneficial. There are patients that I've met that probably were not yet for DBS, but they wanted a better quality of life, particularly if they had tremor or had very active social life. So in these patients, yes, if they can have it, I don't think is a bad thing. I don't know if Joseph and Antonella want to add anything to this question.
Well, in terms of doing private, the problem with DBS is it requires a long-term follow-up, and if there's not established service there that you can see somebody privately, it becomes a bit difficult. In Queen Square, we even struggle with that. I've always discussed that with the management, that I don't have enough staff to look after all the private as well as the NHS patient. So it becomes a struggle, and it becomes more of a ethical thing for me, where if we can look after them afterwards, then there's no point doing DBS. Better to put them on the NHS pathway.
And then we have a question about how often we review DBS patients, and if they are under the care of another center for medical management. Antonella, do you want to reply?
Yeah. So it depends of the patients how often we need to review. So the first 6 months, for example, after the procedure, we try to see every 2 months if they require more adjustment, but it depends. And then, of course, we can, once the patient is stable, we can meet the patients once a year, especially nowadays that all the provider devices can have the rechargeable batteries. So there is not a white and black answer to this question. It really depends on the patients, how the patient is doing. And if they are under the care of another, the Center for Medical Management, would you lead any medical changes? In the best scenario, it's better that the team that look after the DBS look after also the medication changes, because the two things goes together. However, on the practical side, it's possible that some medical adjustment needs to be done locally. I give you an example about me living in Liverpool, managing patients in North Wales. So what I'm sometimes it's hard for the patients to travel here just for adjustment. So I'm trying to link with the geriatrician that lead movement disorder service there, and the Parkinson nurse that are a key resource in the North Wales. So we try to work together, even with remote discussion. So again, it depends what are the needs and what is the geography where the patients live.
One thing that I think is very important that I want to add is that sometimes there still need to be a very strong collaboration between the DB center and the local center. Because what I usually notice that sometimes the local, the management teams tend to increase the doses of medications, which it should not be, because actually when you have DBS, you need to reduce the doses. And then you have side effects. So it's very important to educate people that the answer is not increasing medications, because medications were not working in the first place. That is why they have DBS. So be very conservative on the medications. Then we have a question on gambling and suicidal complication. Joseph, do you want to answer to that one?
I think in terms of gambling and suicidal, we're very sensitive to that. We always advise patients to call us if there's some signs of ICD. Now, if the patient is actually suicidal, it's always important to work alongside with your neuropsychiatrist, because if you got concerns about that already, then you can refer the patient to your own neuropsychiatry. But if there's an imminent risk for the patient, then you can contact the local team to actually see the patient, how much risk there is for the patient, or they need to be admitted locally. They have.
And then there is a question about what to do if people develop ICB or while on DBS. Usually the first thing that we try to do is to look at where the contacts are, because sometimes if the contacts are too ventral, there might be a stimulation of the limbic system, which might contribute to this symptom. So you tend to just readjust and move the stimulation to more dorsal, where the motor part of the STN is. And then the next thing is to try and reduce the medication that are responsible, trying to tapering them. And usually this is a problem that is solved. Sometimes we also see patients that used to have also ICB, but it was not somehow manifest because the mobility was very reduced. So it came out after they were more mobile and they were more independent. So that's also need to be considered. And then there is a question about affective symptoms of depression. Antonella, do you want to answer to that one?
Yes, it's not very clear. So does it mean this question that the DBS improved the depression?
Yes.
Yeah. Okay. in some patients, yes, there is a general improvement also of the non-motor symptoms, has been shown in some studies, not always confirmed. Again, it depends if together with the depression, there is also anxiety, there is other comorbidities there. But of course, organic depression can improve, and of course, they feel better. They improve the apathy because the motor symptoms are improving, and also the depression can get better.
Okay, I'll answer to this one about oral levodopa. Usually when we give oral levodopa, the challenge, we give a very suprathreshold dose, which is 300 milligrams of levodopa. So it's more than the usual treatment. That's because we want to really push to see if the symptoms that the patients are dopaminergic or non-dopaminergic responsive. He also, so if there are some symptoms that are still there after 300 milligrams, we can tell the patient, look, these symptoms are not going to improve. If these are your priority, unfortunately, DBS will not go do anything for you. You will take the risks of the surgery, but these symptoms will not improve. It's also good to check because people have a very good on, and that is what we can give to them with DBS. We can't get anything above that. If they have a poor response, again, we cannot go more than that. So that is a good way to test what are the expectations, because if they are not happy with the best on that they have with 300 milligrams of levodopa, they won't be happy with DBS either. So what the next one is, what is the strategy when the surgical complication that affect some new symptoms, yet the Parkinson state is still there? For example, a small hematoma. The strategy is to usually this the small hematoma, the bleeding occurs in about 2-3% of surgery, and usually are very minimal, and they tend to improve in about a month or so. We tend to wait for this to recover, so we switch the stimulation a little bit later and wait for the recover. I don't know if anyone else want to add anything to that question.
No, I completely agree. So it needs to be treated as all the neurosurgical, hematoma, and give time.
Usually what we see of new complications, sometimes of the surgical complication for me, is apraxia of eyelid. Sometimes people tend to have, they don't manage to open the eyes, and that is could be related to the stimulation, but also to the surgery itself, because even if you, usually all these side effects are related to stimulation. So if you go down with stimulation, they disappear. The apraxia of eyelids usually doesn't, so it could be a complication of surgery. And then there is a question on the keeping balance between DBS and oral medication. Short term after DBS, insertion of and long term. Okay, so again, you need to consider that the idea is that DBS is replacing the effect of dopamine. So both work as a brake on the STN or the GPI. So you need to find the balance. Usually the reduction over time need to be done very, very slowly, because people might have high level of dopamine reaching other parts of the brain, the ventral striatum. So, and that reduction, even if it's not needed for the Parkinson anymore, can give problems in this other area. So you need to go very, very slowly down with medication. In fact, some of the suicides that were registered after DBS probably were related to a dopamine agonist withdrawal syndrome. So that's very, very slowly. And then over time, it's always better, in my opinion, to try to increase DBS rather than tailor DBS rather than adding new medication. But that also depends, because sometimes if you have side effects with DBS, you can't go very high, so you need to have other medication. So it depends from person to person. Joseph, Antonella, do you want to add anything else? We are very close now to
to the time.
The time of the break. If we can have these questions, we can answer after the meeting. So we will answer to everyone. Or we feel free to drop us emails. And we will answer to these questions that are all very interesting. So it's a shame that we don't have time to answer to all of them. But thank you everyone for taking part.